Good morning. This is the Syphilis in Pregnancy-TOG article summarized to help you with your revision of MRCOG exams. I hope you'll find this useful, and don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. So syphilis is a bacterial sexually transmitted infection. It's caused by Treponema pallidum. It's the most common congenital infection worldwide. Greater than 50% of syphilis in the UK is actually in London. 75% of all diagnoses are in men who have sex with other men. Syphilis co-infection with HIV is not uncommon, and according to recent UK data, it's seen in about 40% of patients. Infection remains part of antenatal screening program in the UK. So syphilis is prevalent in Africa, South America, Southeast Asia, and Eastern Europe. It's a leading infective cause of stillbirth in countries where it's still an endemic. If an expectant mother has syphilis, the mother-to-fetus transmission can occur, leading to quite potentially serious adverse sequelae, including low birth weight, stillbirth, and congenital syphilis. In the UK, 1 in 700 to 1 in 7,000 screen positive for syphilis annually between 2008 and 2018. 40% who screened positive required antibiotic treatment for the condition at the time. Risk factors are low socioeconomic status, multiparity, history of sexually transmitted infections, use of illicit drugs before the age of 18, or illicit drug use by the current partner, poor engagement with antenatal care, and 3 or more sexual partners in the previous 12 months. The transmission is mostly via sexual contact. 1/3 of individuals exposed will become infected. Bacteria can also enter extragenitally via anal, rectal, or oral routes. Transmission can occur transplacentally during any stage of pregnancy. Risk of transmission is dependent on stage of maternal infection and duration of fetal exposure. Stages of syphilis. So syphilis is characterized by a relapsing, remitting course. The early stage of disease has symptoms of primary and secondary syphilis, followed by a latent or hidden syphilis, during which there's no clinical signs or symptoms, but the patient remains infectious, and as such, serological blood test will be positive. Early latent syphilis describes infections that occurred within the past year, whereas late latent syphilis describes infections that occurred more than a year ago. 20 years later, stigmata of tertiary or late syphilis, termed late stage disease, happens, and that's unlikely in the obstetric populations. Complications like neurological, gametose, and cardiovascular may be seen. So primary syphilis, approximately 3 weeks following exposure to infection, a single papule site at which bacteria enter the body becomes a canker, a painless and indurated, non-purulent lesion. If outside genital tract, cankers can be multiple and painful. Cankers typically heal spontaneously over 3 to 8 weeks. 25% of patients will go on to developing secondary syphilis if they do not receive treatment. The secondary syphilis is a systemic manifestation of syphilis, often emerges 4 to 10 weeks after development of primary canker. Includes the following: so general malaise, flu-like symptoms, loss of appetite, lymphadenopathy, generalized mucocutaneous rash, which typically affects mucous membranes and on palms and soles. Development of perianal condylomata, discolored, warty, highly infectious lesions. These can also be extragenital. Other signs like meningitis, eye disease, hepatitis, glomerulonephritis, and splenomegaly. Secondary syphilis resolves within 1 to 3 months before entering a dormant or latent phase. However, in up to 1/4 of patients will develop recurrence of their secondary disease in the initial part of this latent period. If untreated, 30% of patients will progress to tertiary or late syphilis with its associated cardiovascular and neurological manifestations. So syphilis in pregnancy, the risk increases as pregnancy progresses towards term. Fetal loss is common, demise of 30 to 40% of fetuses. Of the fetuses that survive, 1/3 will be born with signs of congenital syphilis. Transmission is as high as 100% in primary syphilis and in early 40% and in latent syphilis is 10%. Fetal ultrasonic features. So fetal infections is initially characterized by placental involvement and hepatic dysfunction, results in fetal growth restriction, hepatomegaly, thrombocytopenia, anemia, ascites, with subsequent risk of preterm birth, stillbirth, and neonatal death. Signs on ultrasound are distorted fetal long bones or fetal hydrops. 6 to 10% of cases of fetal hydrops are associated with congenital infections. Although the mechanisms can vary, fetal hydrops caused by treponema infection typically occurs as a result of disseminated damage to capillaries and endothelial cells, which results in fluid shift. So fetal ultrasound features that are typical of syphilis are ascites, hepatosplenomegaly, intrahepatic calcification, and placentalomegaly. Laboratory testing and diagnosis, or direct testing methods like isolating the organism, including dark field microscopy and PCR, have benefit of detecting the bacteria before a serological response happens, therefore yielding more results more quickly. Serological tests like enzyme immune assays and T pallidum particle agglutination assays detect antibodies to the treponemal proteins or to non-treponemal antigens such as damaged host cells or lipoidal antigens. Treponemal serological testing, further serology, so non-treponemal serological test, because there's genuine risk of false reactivity, especially with other infections or inflammatory conditions like SLE. If they're reported as reactive or non-reactive, they do not give any information about the stage of disease or whether it has been treated. The non-treponemal serological tests include rapid plasma reagin and venereal disease research laboratory carbon antigen tests. These assays react with immunoglobulin M and G antibodies and demonstrate disease activity through their titer levels. These titers should reduce over time and will subsequently become negative or undetectable once treatment is completed. False positives show raised antibody response to other endemic treponemal conditions like yaws or other systemic inflammatory conditions such as endocarditis. Notably, this method can also give false positives because of pregnancy itself. So what does a NICE guideline recommend for testing for syphilis? Send 10 ml of clotted blood sample to obtain a full syphilis screen. Swab lesion on genitals or elsewhere with a flock swab. Send these for syphilis PCR and also to test for herpes simplex as a differential diagnosis. Use this opportunity to screen for other STIs including chlamydia, hepatitis B, C, HIV if after patient consent. So Public Health England recommends that if the first syphilis serology screen returns as reactive or positive, then a second sample should be sent to test for an alternative treponemal antibody to confirm the disease. Rapid plasma reagin test performed prior to treatment to establish baseline titer levels at the highest point. If results are negative and there's still suspicion of syphilis, repeat serology should be sent at 6 and 12 weeks after date of last sexual contact to allow for incubation period. Although spirochetes are seen in circulation relatively quickly after they breach the mucocutaneous defenses, antibody levels often do not rise for many weeks. False negatives are also commonly seen in HIV positive patients. BASH recommends repeat testing for high risk of syphilis exposure, including unprotected vaginal, anal, or oral intercourse with homosexual men, commercial sex workers, who may inject drugs, sexual partner who have high disease prevalence, example African countries, and multiple sexual partners, or partner with a diagnosed STI. Repeat testing every 3 months. NICE recommends suspected disease. So patients who you're suspecting a syphilis in who decline testing or confirmed syphilis who decline treatment, who knowingly transmit the disease via sexual contact or non-sexual contact with extranegenital lesions, these acts, the patient should be made aware that these acts could result in prosecution. So treatment is an MDT approach. So gum physicians, neonatologists, and microbiologists should be informed. Antimicrobial therapy is to be given. Counseling needs to happen with the patient. Partner notification and safe sex advice. Treat as soon as diagnosis is established. The earlier in pregnancy, the better. Treatment at least 30 days before delivery is possibly the most important factor influencing risk of congenital infection and perinatal mortality. Treatment of early disease as recommended by WHO is with a stat dose of IM, benzathine, penicillin G, 2.4 million units. Second dose is recommended for treatment of early disease in third trimester because there are lower serum levels of the drug and a risk of treatment failure. For patients who report sensitivity to penicillin and who can tolerate cephalosporins, then alternative with ceftriaxone 500 mg IM daily for 10 days. If penicillin intolerant or allergic, thorough drug history should be taken and urgent referral to allergy services and immunology should take place to establish true allergy. Ultimately, antibiotic management should be individualized in collaboration with gum services. If not penicillin allergic but unable to tolerate intramuscular injections, an alternative with amoxicillin 500 mg and probenecid 500 mg orally 4 times a day for 14 days. So this is a particular form of reaction. I will leave you to pronounce this, but this complicates up to 45% of syphilis treatment in pregnancy, associated with large numbers of Treponema pallidum being killed, which releases lots of cytokines and initiates an acute inflammatory reaction. In the first 24 hours of treatment, symptoms include fever, rigors, skin rash, uterine contractions have also been reported. 50%, it's common in early disease, 50% of primary syphilis, 90% of secondary syphilis. Latent disease has a reaction rate of about 25%. Symptoms are generally self-limiting, supportive care, and symptom control is advised. Okay, so this is the suggested screening algorithm for syphilis. It's by BASH. So screen at booking. So treponemal serology to detect both IgG and IgM. If positive, confirmatory screening test required. If negative, you do nothing. So it's positive, then send original sample for a different treponemal serological test, and send a second sample for treponemal serology. Confirmatory samples are positive, then perform quantitative RPR or VDRL tests to elicit antibody titers or to use for monitoring before starting treatment, then repeat 3 monthly. Refer to gum and pediatric and neonatal care to commence complete BASH congenital syphilis birth plan. Offer repeat screening 3 monthly. Consider this if women declined a booking or if any of the following risk factors for high risk of exposure apply, like new or multiple sexual partners, commercial sex worker, sexual contact with MSM, which is men who have sex with men. A sexual partner is from a country with high prevalence, that's Africa, Southeast Asia, or South America. Okay, so antibiotic treatment advice for using syphilis in pregnancy is if the first and second trimester and it's early disease, then it's benzathine, penicillin 2.4 million units IM single dose. If it's late disease, then it's benzathine, penicillin 2.4 million units IM weekly for 3 weeks. If it's third trimester, the treatment is benzathine penicillin, 2.4 million units IM weekly for 2 weeks. And if it is third trimester but late disease, then you still use the benzathine penicillin, 2.4 million units IM weekly for 3 weeks. So congenital syphilis is rare in UK. Congenital syphilis can be divided into early and late disease depending on time of presentation. Early disease is first 2 years of life. Late congenital syphilis is after age of 2 years. 2/3 of babies with congenital syphilis are asymptomatic at birth, and of these, 2/3 will demonstrate signs and symptoms from 3 to 8 weeks of age. Most present before 12 weeks of age. Congenital syphilis is a multi-system infection that can result in neonatal death and long-term disability. Signs of early disease include skin rashes, stigmata of meningitis, jaundice, hepatosplenomegaly is a common finding with raised alkaline phosphatase levels. Blood tests show severe anemia, monocytosis, and thrombocytopenia. X-rays may demonstrate periostitis, which leads to development of bone deformity. Bloody snuffles caused by syphilitic rhinitis creates pink-colored nasal discharge. Late disease typically presents with bony deformity secondary to chronic inflammation. Clinical manifestation of congenital syphilis has a Huntington's triad, eighth cranial nerve deafness, interstitial keratitis, and Huntington's teeth notched incisors. Syphilitic rhinitis leads to a characteristic saddle nose and anterior bowing of mid-tibia, creates the classic Sabrschin's effect. Late congenital disease can be devastating. 1/3 to 1/4 of children presenting over the age of 2 years have asymptomatic neurosyphilis. Babies born with congenital syphilis are 10% more likely to die in the first year of life. Well, that's it. That's the summary of this TOG article. I remember trying to revise this for my exam and how I would attempt to read it every single time, but I would just lose interest and lose concentration, and I had to keep going over it and force myself to keep reading and create these summaries to be able to understand and follow it through. Otherwise, it was impossible for me to retain the important points from this article. So I hope this video has really resonated with you and you found it useful. And if you have, then please give this video a thumbs up and subscribe to my channel if you haven't already, and share this channel with your friends and colleagues, and also comment if there's anything in specific that you'd like to watch on this channel which will help you to revise for your MRCOG exams. Good luck with revision.